It's here in Europe, it's 5 o'clock and it's 11 o'clock Eastern Daylight Time. So time to start. So welcome everybody. We're here for the April edition of the CMR Journal Club, and on behalf of the co-lead, Nicole Seiberlich, who's also on the call, I welcome you to look at two very interesting papers with a kind of a strong clinical relevance, and it's about infarct severity. And just by coincidence, I think two remarkable papers were recently published. One from the group of Sebastian Reinstadler, that's going to be presented by Ivan Lechner, and one from Andreas Kumar, with the first author on behalf of a Canadian consensus group. So the first paper published in the Journal of American Heart Association, it's entitled Temporal Trends in Infarct Severity Outcomes in ST Segment Elevation Myocardial Infarction, a Cardiac Magnetic Resonance Imaging Study. So this is about, let's say, looking at outcomes with CMR. And we know that CMR is, that's an easy statement, is the best method to not only look at myocardial infarction, but also phenotype it and assess its severity and impact on outcomes. So Ivan, take it from here. The next 10 minutes are yours, and then we have hopefully some time for discussion before we go to Andreas' paper.
Yeah, thank you very much for the invitation. I hope you can hear me well, because
yes,
we are currently at the German Society of Cardiology meeting. So we are sitting here in a lecture room. So I hope that the sound is quite okay.
Yeah, no, it's good.
I'm joined here with Sebastian Reinstadler, the leader of our research group, and yeah, I will guide you through our paper, which we have published in JAR.
Yeah.
As you already said, it's about the temporal trends, and I would like to start with the introduction, because as you all know, the impact of STEMI is still relevant in the Western world or worldwide, because it has still a significant morbidity and death worldwide. And despite this significant impact, there is an improvement due to the implementation of therapies such as interventional therapies or medical therapies. But there is also data that since the early 2000s, around 2008, the outcomes has plateaued. So there was no significant improvement from this time on. And there was also a very nice paper from, I think it was Carolina Zummer, from the Sweetheart Registry, and she could show that the outcomes improved over the last years, but they stopped to improve after the early 2000s. And so we wanted to know, why isn't there a stop, or why isn't there a plateau in improvement? Was it about infarct size? Was it other things? And so that was the reason why we wanted to look inside the myocardium through cardiac magnetic resonance imaging. And as we know that the infarct size is very relevant in the outcome of STEMI patients, you all know the paper or the meta-analysis from Greg Stone, who could show that every 5% of increase in infarct size results in a 20% increase in MACE. That was the reason why I wanted to look, is there any change in myocardial infarct size, or is there any change in microvascular obstruction or intramyocardial hemorrhage through these years? And that was the reason why we started this study. We included patients from the Marina STEMI study, which is a prospective observational study, and from the predecessor study, which combines patients from 2005 to 2021, which is roughly a 15-year time period. And we looked in these patients on the level of the tissue damage, like infarct size, microvascular obstruction, the intramyocardial hemorrhage. I'd like to start to jump to the central illustration, because I can show it here very nicely. We included a bit more than 800 patients. All of them were treated with primary PCI. As already said, this was a 15 years time span, and we made a multi-parametric cardiac MRI imaging from all these patients. If we jump to the results, you can see that the median age was 75 years, similar like in the Sweetheart Registry. 70% of patients were female, and we saw that there was a significant decrease in the occurrence of hypertension and in the occurrence of hyperlipidemia. Furthermore, we saw that the door to balloon time, which you can see here, also significantly decreased. And more importantly, that the treatments or the periprocedural treatment and the discharge medication also significantly improved in these patients. So we saw a shift from second generation P2Y12 inhibitors to third generation P2Y12 inhibitors for the periprocedural therapy and for the discharge medication. And we saw also that all medications which are known to be of prognostic significance, such as beta blockers, MRA, RNA, SGLT2 inhibitors, and statins, they also increased from over the 15-year time span. So we had a situation that all these things which we know that are of prognostic significance increased, but we didn't saw any impact on this on the myocardial infarct size. So I spoiled a little bit, but would like to go on with other baseline characteristic. You see that the thrombectomy significantly decreased, which is in line with the guidelines. And when we now look at the main findings of the cardiac MRI parameters, we can see that over this time period, so from period 1, 2, and 3, we saw absolutely no change in infarct size. So P value was 0.25, and we also didn't saw any significant difference in microvascular obstruction or on intramyocardial hemorrhage. Furthermore, also the left ventricular ejection fraction or all other parameters, they also didn't show any significant difference in these patients. Here in this illustration, you see again the microvascular injury. You see microvascular obstruction and intramyocardial hemorrhage. In the first period, we couldn't assess any intramyocardial hemorrhage because we started with this, this technique in 2015 in our center. And as I said before, also the left ventricular ejection fraction, similar to the infarct size, was also no significant difference. We also then looked in the outcome of these patients, and we did a Kaplan-Meier analysis from every 3 periods. And here again, we didn't see any significant difference in the outcome of these patients. So basically the findings from Carolina's tumor, we could expand these because we saw them in a time frame after 2008. And we could also show at the myocardial and microvascular level that there was also no significant change at all. So I would like to conclude that in our study, the severity of myocardial infarction or myocardial tissue damage didn't change at all over the 15 years time span. And so, as you know, right now we are still in this plateau, and we still need any or novel devices or novel treatment options for these patients to improve this outcome, because we also know that besides the tissue damage for the infarct size per se, the microvascular injury is of major importance, as we will see in the second talk as well. Thank you very much.
Thank you. So in a nutshell, there is no change that you could observe, so the coincidence with the temporal changes of mortality. So you also think this coincides that there was also no overall change of mortality due to myocardial infarction. So this, you think that was basically consistent with the mortality data?
Yeah, basically we don't know, because as we have just observed the observational data, we can't really say if this is the reason for this. But as we know that the infarct size, the microvascular injury, such as intramyocardial hemorrhage and microvascular obstruction, has very strong implications in STEMI patients. This could be a sign that there is no improvement. And we know from many other studies that in recent years we weren't able to target microvascular injury with any trials. There are a few concepts such as cooling or other concepts, but until now we weren't able to target this important issue. And as we will see in the second study, we think that microvascular injury has a very has a very strong prognostic implication. And as we couldn't see any difference, maybe this is also a reason for the missing difference in outcome. As that observational isn't always the truth, but it's a sign at least.
Yeah. No, I agree. So maybe just briefly before we move on, how did you quantify infarct size? There are several methods. Were they always the same? Did you use full width half max or a certain standard deviation above remote, or how did you? We
use the same method since 2005. It's also always the 5 standard deviations of the remote myocardium. There is until now no clear definition. What is the best definition? Also from the CMR consensus paper. So we use this for a very long time, and I think it's also maybe not the best, but the most established definition, and it's also the reason why we use this. And yes, I said since 2005, basically.
Yeah. Okay. Thank you very much. There is a question in the chat. Ivan, if you could answer that with chat so that everybody can see that, because I want to make sure we have enough time to discuss the second paper. So if you could also unshare your screen, thank you very much. So infarct severity was here defined as infarct size. And infarct size was in the past shown to be associated with outcomes, but it may not be the only important marker to assess the severity and also the prognostic implications of an infarct. And someone who has done already research on that since many years is Andreas Kumar, was initially in Berlin, then in Calgary, spent some time also in Quebec City, and works a lot with the Cedars, or has been working a lot with Cedars-Sinai Medical Center in Canada. And he's lead author of a consensus paper, which will be the next paper we discuss. So Andreas, if you could just take it from here. And tell us about the paper entitled The Canadian Cardiovascular Society Classification of Acute Atherothrombotic Myocardial Infarction based on stages of tissue injury severity, an expert consensus statement.
Thank you very much, Matthias. I appreciate the invitation. Just before diving in, I'd like to acknowledge, of course, that I had the huge privilege of working with you for many, many years, and a lot of the initial work that actually went into this classification what started the ideas. Many of the ideas started in your lab. So this is a new idea that we are publishing here that was published in the January edition of the Canadian Journal of Cardiology, and it was then published again in the European Heart Journal just about 2 or 3 weeks ago. What we are proposing in with this expert group is that we really need to start looking at myocardial infarction differently. And not all myocardial infarctions are the same. And when you start looking at tissue injury, then there's actually a lot of information to gain here. And that information actually allows for a new classification of myocardial infarction. And I'd like to start with this figure. This is from the visual abstract. The basic idea underlying this new classification of myocardial infarction is that on a tissue level, not all myocardial infarctions are the same. So in the clinical setting, we distinguish STEMI and non-STEMI, which is, of course, super powerful with its therapeutic and prognostic implications. Then we use risk scores like the KILLIP score. But the power of tissue injury is really not being exploited very well. And if we start looking at this in terms of a new classification, that could actually help facilitate clinical care. The underlying observation of the new classification is that the tissue injury in acute reperfused myocardial infarction occurs in stages. It's a cascade of injury that occurs one after another. And at every progressive step, there's a new specific injury that gets added to the previous injury. So the Canadian classification, the CCS classification, Canadian Cardiovascular Society classification of acute myocardial infarction, divides tissue injury in 4 stages. The first stage is aborted myocardial infarction. You can see on the schematic a short axis representation of the left ventricle. And at stage 1 of tissue injury, we will have myocardial edema, which will identify acute tissue injury, acute ischemic injury. But at the very early stages, within the first hour, the so-called golden hour, there's actually no cardiomyocyte necrosis yet. So if the patient gets treated and reperfused at this time, then we can actually save essentially all of the myocardium that is at risk. So aborted myocardial infarction, characterized by myocardial edema, is CCS stage 1. As injury progresses, there's a wavefront of tissue injury that starts with cardiomyocyte necrosis in the subendocardium that was described by Reimer and Jennings in 1978. And as time goes by, the wavefront of necrosis will then be more and more transmural. And this is consistently being observed with cardiac MRI. So the second stage of tissue injury, CCS stage 2 infarction, is cardiomyocyte necrosis. Edema is already present from stage 1, and cardiomyocyte necrosis gets added at stage 2. Importantly, at this stage, there's no microvascular injury yet, no observable microvascular injury. There's no microvascular obstruction, and there's no hemorrhage. Hemorrhage and microvascular obstruction will define stages 3 and stage 4. So at stage 3, we have edema and cardiomyocyte necrosis, and microvascular obstruction is now the next step of injury. And this is based on the observation that microvascular obstruction always occurs in the presence of edema and cardiomyocyte necrosis that are already present from stage 1 and stage 2. So it's kind of the next stage of injury. Microvascular obstruction first described in 1974 by Robert Kloner in a paper in Circulation at that time. And he could already show at that time, 50 years ago, that microvascular obstruction is a more severe type of tissue injury, and it occurs temporarily later than cardiomyocyte necrosis. So this is stage 3. And at stage 4, we have hemorrhagic myocardial infarction, where you have cardiomyocyte necrosis and microvascular necrosis. And if you reperfuse in a territory like this, you will end up with hemorrhagic myocardial infarction. And again, this is observed only in the presence of edema plus necrosis plus microvascular obstruction. Hemorrhage is never observed alone. So we really have a cascade of 4 steps of injury, CCS stage 1, 2, 3, and 4. Now, the imaging data that have been published show that with each stage, there is a progressive loss of salvageable myocardium. There's a progressive increase in severity of tissue injury. And with hemorrhagic myocardial infarction, we have learned in a paper that we published last year in JACC that there is actually infarct expansion and an additional type of injury with very specific implications for biochemical and cellular processes that are not observed in non-hemorrhagic myocardial infarction. So injury gets larger after reperfusion therapy in the 72 hours after reperfusion therapy. So hemorrhagic MI is an entire different beast. So progressive injury severity. And I like to show another figure from this paper that we really went back and looked at all the data that had been published around this. And we could see that there's a progressive increase in major adverse cardiovascular event rates. So there's an increase 2 to 10 times when you leave the stage of abortive MI and you go to a more advanced MI. We're talking about an increase of almost 10 times, some studies more than 10 times in adverse event rates when you go beyond abortive MI. The moment you add microvascular injury and you go to patients that have microvascular obstruction as opposed to no microvascular obstruction, event rate goes up 2 to 4 times. And there's studies looking at hemorrhagic MI and hemorrhagic versus non-hemorrhagic MI. The MACE rate goes up 2 to 6 times. So this new classification gives us a new perspective. Not all myocardial infarctions are the same. It is associated, reflects the progressive tissue injury, which then is reflected in major adverse cardiovascular event rates. Now, what are the implications of this? We believe that this is actually quite fundamental because it would, first of all, refine our understanding and bring the complex tissue injuries in an easily applicable format to the clinical setting. This can be used as a risk stratification tool. You may have 2 patients with a STEMI in bed 1 and bed 2 in your coronary care unit. But if you apply the CCS classification, you will be quickly able to identify who's at a high likelihood of not doing well, as opposed to somebody who perhaps has an aborted MI CCS1 and who will actually do very well. There's also major implications for research. And I'd like to go back to the paper that was just presented a few minutes ago. You could see very well that sadly, we have not made much progress in terms of infarct size, infarction reduction or cardioprotection in the last 10, 15, 20 years. I believe that part of this is because we were focusing on the coronary arteries, which was great and brought us a lot of progress in cardiology. But I think if we shift our intention to the myocardium, we will be able to extract these different tissue injuries. And I think that we need to provide therapies that are specific for hemorrhagic infarction, specific for microvascular obstruction. If we start to focus on that, we will be able to develop better therapies, more specific therapies, have more personalized care for our patients. And I think this may be opening up the doors for research in the future. Also, this classification can be used for outcome measures in therapeutic trials. If you do an intervention or a trial using a certain medication, or you're changing your infarction protocols at the hospital, if those interventions are effective, then you should start to see less CCS stage 4, less hemorrhagic MI, less microvascular obstruction. You should be able to halt injury at an earlier stage, for example, ideally at stage 1 where you have aborted myocardial infarction. There's much more in the paper, but I think this is a condensed summary. We have all the diagnostic criteria, and perhaps I'll leave it up for discussion now, Matthias.
Thank you very much, Andreas, for the very clear and excellent presentation. And I agree with you that looking at the coronaries alone will not help much more than what was already achieved. We were actually, in cardiology, we got much better in the strategies, how to open coronary arteries, when to open them, using which devices and using which stents to try to keep them open, the anticoagulation therapy around it. So that was all pretty much maxed out from my point of view. But this will not lead us further if we do not have a good understanding of what's happening in the tissue. And I think this paper is, to me, a very important landmark, because it kind of summarizes all the important research that has been done, but that many people do not put together. And I think a classification like that is very helpful. I have, however, one, so to me, and I know we have discussed this a lot, but I will still ask it. When I see stage, to me, this sounds like the infarct is going through these stages if you don't do something about it. And that is true probably for stages 1 to 3, whereas 4 to me was always a problem that occurred in reperfused infarcts. So in the physiology, which is interesting, the cardiomyocyte dies first. The endothelial cells, they hang in a little bit longer. But if you wait long enough, then the junctions, the tight junctions get loose. And if you then reperfuse, you have extravasation of erythrocytes, which is a disaster in the body because it triggers a very strong inflammatory response with compression of capillaries, and then, as you rightfully state here, infarct expansion. So to me, stage 4 is more a complication of our therapy, not necessarily a continuous stage from 3. So what are your thoughts on that?
I think you're raising an excellent point, Matthias. We're being very clear about this in the paper. All the data that went into this paper are based on acute reperfused myocardial infarction, because there's really not much research being done on non-reperfused myocardial infarction. We have data on non-reperfused MI from the 60s and 70s, but every patient nowadays will rightfully, hopefully, get reperfused. So this is a classification, and we put this even in the title, it's a classification of acute reperfused myocardial infarction. Hemorrhage occurs with reperfused myocardial infarction. Microvascular obstruction is diagnosed with reduced coronary flow when the epicardial artery has been opened up. So all of these apply to reperfused MI. We don't know whether or not they apply to non-reperfused, but I think there's a lot of interesting research to be done there.
Yeah, no, I agree. We have some data that have not been published yet because there were too many people involved. But we looked at the relationship between the damage done and the salvage, and then the time to balloon. It's always difficult, time to balloon, because when symptoms start, it's sometimes difficult to clearly define, and then what is the time when it was really open, the vessel. So there's a lot of wishy-washy at these to determine the time. But from what I have seen also in my time as a clinical cardiologist, I think there is a window that closes maybe after 6 to 8 hours. And if we do not reperfuse during that time, there may be more damage than harm for a few hours, because then you have this open endothelium and you have hemorrhage, which then gets to stage 4, which is the worst that you can imagine, probably even worse than just leaving the vessel, unless the patient has still symptoms and has ischemia. So, but this is, as you said, this is, I think, very important that some research is done on that. Yeah, so that's why I think this paper is very important. So there's a question from Vic Ferrari. Vic, I don't know whether you want to speak up yourself, but I'm happy to read it. So Vic asks, do you think a different reperfused strategy is necessary with PCI regarding reduction of free radical formation, etc.? So this is, of course, a clinical question from a clinical cardiologist who is one of the world experts in CMR, by the way. So Andreas,
first of all, it's a huge honor to have Vic Ferrari on here today. Can't see you, Vic, but hope you're doing well. It's great to have you. So I think your question is just perfect, and we're alluding to this in the paper. Especially hemorrhagic myocardial infarction is a very, very dangerous thing. There's actually pathology studies that have very closely associated hemorrhagic myocardial infarction with myocardial rupture, sudden death from mechanical complications. So the question is exactly how do we reduce the impact or the burden of hemorrhagic myocardial infarction? If I can go back to the paper, there's a number of risk factors that were identified. We call this the injury clock. So there's a number of factors that are associated with infarct progression. The most important is time. But I do not have a clear answer to reperfusion strategies. There's a lot of therapy, a lot of research that needs to be done. Indeed, it seems tempting to believe that if there's a way that we can manipulate reperfusion strategies in a way that we could reduce hemorrhage, that would be great. I don't know what those therapies would be. We have ideas of reducing the pressure with reperfusion, having therapies specifically directed at hemorrhage. This is all a new field that needs to be explored. But what we wanted to provide with this classification is precisely the attention. I think we need a shift in attention in myocardial infarction research. We've been focusing on the vessels and reperfusion strategies, reperfusion time, as Matthias, you alluded to so beautifully, eloquently. But I think the time has come now where we need to shift our attention to the damage, because the damage happens at the myocardial level, at the microvascular level. And I think we're opening up with the classification and a new way of looking at things and hopefully providing new therapies. And absolutely, maybe those are free radical directed therapies. Maybe those are reperfusion strategy related therapies. I don't know. The future research will have to show. But we're providing the basis to have a look at this with the eyes of the classification, because not all myocardial infarctions are the same. And right now we're treating them all the same. And this just can't be right. This just can't be right. If we start to take tissue injury into account, then we will start to open the doors for tissue injury directed therapies. And that's where we need to go, I believe.
This data is so valuable, Andreas, and the classification, I think, is going to be extremely helpful. As you alluded to, we've been doing the same thing when it comes to reperfusion, for decades. That hasn't changed. And if we want to move the needle on reperfusion injury and hemorrhage and microvascular obstruction, I think we have to think about the way that we're reperfusing. the myocardium as well as everything you've identified as well. It's fantastic work. Congratulations.
Thank you very much, Fink.
Thank you very much. So we're at the bottom of the hour, and I want to thank Ivan and Andreas. I think it was an outstanding, for me at least, outstanding journal club today. The recording of this is available. Beat the drums for that. I know that many in the Asian time zones primarily live from the recordings, and we get the good feedback from there. And I think this was very helpful. Before we conclude, I want to ask Nicole to announce the next CMR Journal Club, the May edition.
Yes, so if it would be possible for me to share my screen.
Yeah, Andreas, can you unshare?
Okay, perfect. Okay, so hopefully you can see my slide now. So our next CMR Journal Club is going to be held on May 1st at the usual time, now that we don't have to deal with daylight savings anymore. And so the focus of this journal club will be looking at CESS techniques and applications. So, of course, we're all familiar with T1 weighted, T2 weighted, diffusion weighted images, looking at late enhancement. But there are other contrasts that are emerging as also potentially interesting. And one of these is chemical exchange saturation transfer, or CEST. And so our first paper is going to be looking at a potential clinical application of CEST, so using CEST contrast as a potential replacement for ECV in patients with light chain amyloidosis. And then the second paper is going to delve into some of the more technical aspects. So CEST is not necessarily an easy contrast to generate in the heart. And so this paper on the right-hand side is going to talk about some of the improvements in how we can generate this CEST contrast for more homogeneous and improved both spatial and spectral localization of some of the myocardial energetic species that we can target with the CEST contrast. So join us if you're interested in hearing all about CEST on May 1st.
Thank you very much, Nicole. And again, thanks to the presenters for making this such an interesting journal club today. Stay well, everybody, and safe, and see you next time. Bye-bye.